Thank you very much. It is a pleasure to be here. Very happy to be here. Today I want to talk about a couple initiatives going on in the neighboring state here, Rhode Island, related to pre-exposure prophylaxis, PrEP, as well as some other HIV prevention initiatives and how they all tie together. So my objectives today, I want to talk about PrEP. I'm going to talk about some HIV and STD testing as well, and talk about the role of implementation in our state. I'm in the third year of a K-23. My K-23 is through NIAID, and it focuses on HIV prevention in Rhode Island. It actually involves some molecular epi work, which I'm not going to be talking about today, but the main focus is HIV prevention. For full disclosures, we did get a small grant from Gilead Sciences, and I'm going to talk about that implementation project. And we also get funding from the Rhode Island Department of Health. So part of what I'm going to talk about today is STDs and PrEP in the setting of an STD. So I wanted to pose a question to the audience, sort of as an icebreaker. Don't shout out the answer quite yet. The question is, what is the most common STD in the United States? Now, I don't know many people in this room, of course, but one thing that I'm very passionate about is March Madness. And so, let's see, cut off the top of my slide here. So, okay, with a show of hands, going down the brackets here, which STD is more common in the United States in terms of number of new diagnoses? HIV or gonorrhea? How many people say HIV? I think everyone already saw the answer, so we'll skip. Hepatitis B or human papillomavirus that causes cervical cancer. How many people say hepatitis B? A couple hands. HPV? A lot more hands, and you are correct. Chlamydia and syphilis. Which one is more common, chlamydia or syphilis? How many people say chlamydia? How many people say syphilis? A couple. Chlamydia. And human herpes simplex virus or trichomonas. How many people say herpes simplex virus? Good. How many people say trichomonas? It's about 50-50. So trichomonas is the most common. It gets harder. Gonorrhea and HPV. How many people say gonorrhea? Okay, a few percent. HPV? The majority. You're correct. HPV. How about chlamydia and trichomonas? This one's a little bit harder. How many people say chlamydia? How many people say trichomonas? Almost 50-50. It's actually chlamydia. And HPV and chlamydia, who is the winner? How many people say HPV? How many people say chlamydia? Good. So it's actually HPV. And this is really an under-recognized STD in the country. It's estimated about 80% of sexually active adults will acquire this before the age of 50. Just an FYI. I'm not going to talk about HPV today, but that's just a note. And here's the data, if you don't believe me. It's available on the CDC website. Okay, so today I want to talk about pre-exposure prophylaxis. And to sort of understand where we are at the current time, I am going to briefly review some of the studies. Have people had speakers before about PrEP, pre-exposure prophylaxis? Okay, a little bit. So I'm going to go through these a little bit quickly. So in the summer of 2012, the FDA recommended tenofovir emtricitabine, which is Truvada, is approved as PrEP. PrEP, a single pill for HIV-negative people to prevent HIV infection. So a single pill that people can take to prevent HIV infection. And when we look at the 6 major studies that have been done that have shown PrEP efficacy, they're listed here. The authors of the studies, and you could look them up if you wanted, are in the parentheses there. The IPREX, the Partners, the TDF, the FemPrep, the Voice, and the Bangkok tenofovir study. So these 6 studies were really based from around the globe. When you look at where they were centered, really only one of them, the IPREX study, was centered in the United States, or had sites in the United States. The 2 sites in the United States were San Francisco and Boston, right at Fenway Community Health. But the rest of the studies were really looking at other highly HIV prevalent settings, such as Africa and Southeast Asia. When you look at the people enrolled in these studies, it was a very diverse makeup. So again, the IPREX study was the only one that specifically looked at men who have sex with men, as well as transgender women. The other studies tended to look at heterosexual males and females, and the Partners in PrEP looked at serodiscordant couples. When you look at what drug was used in the studies, the majority were using Truvada, tenofovir emtricitabine, versus placebo. Of note, the Bangkok tenofovir study, which was a major study published in Lancet last year, was looking at injection drug use. They only used tenofovir alone, so they were using basically 1/2 of the drug combination. When we look at the efficacy of PrEP, the first study that came out in 2010, IPREX, showed that it had a 44% overall efficacy. And this was the intention to treat analysis, which means that it looked at all comers in the studies, right? So these were people that didn't necessarily take the drug. There were people that fell out, as long as they were initially randomized to the drug versus placebo arm. When you look across the other studies, it's clear that there's about a 60 or 70% efficacy across the other two major studies, Partners PrEP and TDF. And then the IDU study in Bangkok showed about a 50% efficacy, and that was using tenofovir alone. There are a couple major themes that came out of all these trials, and the biggest one was really adherence. And I'm going to talk about this for a little bit. If you look at the people who had detectable drug levels, so you know that these people were actually taking the drug, it's thought that the efficacy of PrEP is much higher. It approaches 80 to 90%. So when you look at the IPREX study, for the people that actually had detectable drug levels, it's shown that the Truvada, the PrEP, was about 92% effective in preventing HIV transmission. So you can see this sort of dichotomy between the overall as well as people who are truly adherent. And in fact, there were two studies, the FemPrep and the VOICE study, that didn't have significant results. And these were women, and these were women who were taking PrEP. And the reason for this is that the people that they think that most of the women in the trial were not taking it. So when they looked at people who said that they were taking the medicine, who reported daily adherence, they found that only 20 to 30% of those people in those trials actually had detectable drug level. So there was this huge dichotomy between what people were reporting to taking the medicine and how many actually took it. And it was thought, and it is the reason pretty much why these trials did not show that PrEP was efficacious. The other theory that's been thrown out there is that tenofovir and tracidivine build up to different levels in the vaginal versus the rectal cavity. So it's thought that among men who have sex with men, the tenofovir specifically, as well as emtricitabine, build up to higher levels and may be more effective, for example, in preventing HIV transmission through anal sex versus in heterosexual transmission, where they build up to a little bit less levels in the vagina. This just sort of drives home the point about adherence. When you look over these studies about detectable drug levels, you can the blue are people that were actually HIV uninfected, and the yellow were people that had HIV infection. But you can see overall, especially in the IPREX, including in the IPREX study, that the overall adherence was pretty low based on detectable drug levels. And this is a key point as PrEP is sort of implemented, as I'll mention in a few minutes. This was a study published about 3 weeks ago, actually, in The Lancet, that did some modeling and some calculating the number needed to treat based on the IPREX study data. So they were asking the question, how many people do you actually have to put on PrEP in order to prevent one HIV infection? Now, the number needed to treat, of course, is dependent on a couple of variables, including efficacy of the trial. But for the IPREX study, what they found was that the number needed to treat was about 62 people. So that says that you'd have to treat about 62 people in order to prevent HIV infection in one person. When you look at the highest risk group, so receptive anal intercourse is the highest risk behavior for HIV infection, that group you needed to treat 36 people to prevent HIV infection, one HIV infection. I thought this was an interesting study, and this was published a few weeks ago in The Lancet. Just to put that in perspective as well, this is some other things that we do in medicine. If you look at the left-hand column, these are some of the preventative strategies that we do to prevent death due to cardiovascular disease. The first column is the intervention, and the second column is the number needed to treat. If you want to look at the very bottom, aspirin, certainly we probably all know a bunch of people that take an aspirin to prevent cardiovascular disease. You actually need to treat 340 people with aspirin in order to prevent one cardiovascular death. So this just sort of puts things in perspective. You can see statins, you need to treat about 126 people to prevent one death, as well as some of the other numbers there as well. I'd also like to remind the audience, this was something that I did a little bit of a review on in the last few years. Condoms. We all talk about condoms as being extremely effective in preventing HIV transmission. When you actually read through the literature, though, and you look at the studies, and this is a Cochrane review, consistent use of condoms is associated with around an 80% reduction in HIV transmission. So this just shows the point that even condoms, which we tend to point to as a gold standard for preventing HIV and other STI transmission, is not 100%. So PrEP implementation. I want to start talking now about PrEP implementation in the United States, including in our state. So when we think about implementing a new intervention, there's sort of three different broad categories that this can fall in terms of studies. The first are the efficacy trials, so the clinical trials, and those are pretty much what I just showed. We know that PrEP is effective, and a lot of the new interventions will go through clinical trials, of course, to show that they're efficacious. The second and third step, really, of implementing an intervention are really so-called demonstration projects, and finally, implementation pilots or clinical programs. How do these differ than efficacy trials? Well, this is looking at different aspects of really rolling out the intervention in the real world. Different things, at least related to PrEP, that are being looked at, including delivery, uptake, adherence, risks, and impact of HIV overall. So as sort of showed on the previous few slides, the PrEP trials have really been done in other international settings. There's been a couple settings in the United States, but for the most part, the PrEP trials have really been in international settings. So that begs the question, is PrEP feasible in the United States? Is it effective? What populations do we target? Cost issues, et cetera. So there's a number of different demonstration projects in the United States. I'll sort of show you, I'll briefly go over these. But these are basically prospective observational cohorts. They're going on in a number of cities as we speak. It's really limited timeline. So they're talking about giving PrEP out for free to populations in some of these high-risk cities, to high-risk populations, and really following them for a period of time to see what happens for people on PrEP. One thing to note is that it's a little bit different from, quote, real-world settings in that these medications are often given out for free. And at least with a couple of programs in the United States, when the sites shut down their demonstration projects, they're actually no longer going to prescribe PrEP medications. I'm not sure, that didn't quite make sense to me, but there's a number of different, for example, STD clinics that don't necessarily have a functioning, I guess, outpatient medical system. And once the demonstration project ends, they're essentially going to stop prescribing PrEP at that site and refer people to other sites. So the demonstration projects are a step of the implementation pathway, but they're certainly different than the real-world final point that we hope to get to. And finally, I'll talk a little bit about about clinical programs and implementation pilots, which is one that we are starting at our site in Rhode Island. So PrEP. So what are some of the questions with PrEP implementation? One of the biggest questions is delivery. So defining and targeting a priority population. So this relates certainly to the cost of PrEP and how effective it is. PrEP is an expensive medication. Let me pose a question to the audience here. How much does a single month of Truvada cost? Any ideas? Just to put it in perspective, right, if you go to Walmart, there's a $4 Walmart list, right? So you can go to Walmart and get a number of hypertensive medications. You can get a number of depression medicines. You can get statins for $4 a month. So how much does a month of Truvada cost? Any guesses? Yep, so at the drugstores, at least in our state, they cost $1,200 a month. So that's pretty expensive, and certainly not something that our system can afford to flood the entire population with PrEP. So something to think about. So the question is, can we target PrEP in a cost-effective way, as well as people who are most at risk? Second question is, where does this fit in with all the other prevention strategies? So in thinking about HIV prevention, certainly we're focusing on PrEP today, but the cornerstone is actually testing, right? If you can't test and diagnose people, then a lot of these other prevention initiatives don't really make sense. So when I think about HIV prevention, and I really love this slide because I think it proves the point, is that these are all different pieces of the puzzle, which PrEP is one of them. But certainly condoms, behavioral counseling, the gold standard, ultimate cure would hopefully be a vaccine. But these are all different components. And where does PrEP fit in? And finally, who is going to prescribe PrEP? Are we talking about primary care doctors, which are prevalent throughout the community? Are we talking about HIV specialists, which tend to be centered at major academic centers? Or are we talking about community clinics and other community service organizations? So these are all questions that are currently being looked at, and people are currently in the process of answering. Once we've identified the population, we need to ask the question, do even people want to take it? Is this something that people are willing to take and want to take? Is there a demand for it? What are some of the attitudes and stigma about PrEP? Why would people want to or not want to take them? And finally, can we also target PrEP to periods in people's life where they're most at risk. So certainly if you think about our own lives or the life of a person, there's going to be certain periods in people's lives where they're having higher risk sex behavior or more at risk of HIV transmission, right? So it would be ideal to be able to put people on PrEP during these highest risk periods to prevent them, so it's not in terms of a long, continuous, lifelong type medication. This is something that we've heard about in our community, and it's also coming down the line. It's the concept of a Truvada whore. So this is a person, if you're on PrEP and you're taking Truvada, people may assume that you're basically whoring yourself out and having multiple sexual partners. So this is something that we've heard in our program, and certainly something to be aware of. And I think illustrates the concept of stigma already in this early stage surrounding PrEP. Adherence. So as I mentioned before, adherence is really one of the key concepts and a reason why a couple of the other trials failed in the international setting. So if people want the medication, are they actually going to take it? And how are people going to take it? There's been some thoughts that people, so there's a number of different ways people can take PrEP. People can take it every day, of course. But there's a number of people that have asked, can you take PrEP so I'm not having sex all the time, I'm just having sex on the weekends, or perhaps just a weekend a month. You know, I like to go away, I like to hit some of the major clubs, but I only do that about one weekend a month. Can I take PrEP a couple days before that big weekend and a couple days after? Is that going to protect me? I've had a couple of people ask me that in clinic. So and these were, one of them at least was a medical person, so they understood, you know, the concept of daily medication adherence. These are smart people. So the question is, do people have to take PrEP all the time for people to be effective? Certainly we counsel people to take it all the time, but even if they don't take it all the time, is it still effective? This was an interesting study based off the IPREX study again. So this was published in Science Translational Medicine a couple of years ago. If you look at the three graphs on the left, this is based on something called the STRAND study. The STRAND study basically took 24 healthy volunteers, HIV negative, gave them Truvada, and looked and followed drug levels. So the y-axis there are drug levels. You can see when people took drug levels 2 times a week, that blue bar around 10 there, that's how much the tenofovir emtricitabine levels. If they took it 4 times a week, it was a little bit higher, and of course if they took it every day, it was higher yet. When they looked at the number of cases of people who had HIV in the IPREX trial, there were 3 people out of the 42 that had detectable drug levels. Those 3 there are in the red upside-down triangles, and you can see that that those levels equate to about a drug level of about 2 times a week, versus the controls you can see, which are a little bit higher, but certainly not up to every day. Based on some of these numbers, it was estimated that PrEP efficacy was about 76% for 2 doses a week, 96% 4 doses a week, and 99% for 7 doses a week. So again, the point here is that, frankly, you know, we don't tell our patients this, but you probably don't have to take PrEP every day for it to be effective. So this isn't something that's widely known or widely counseled about. Certainly it's hard. It would be hard to take PrEP for 4 days a week and be on schedule. But the point is that you don't technically need to take PrEP 7 days a week for it to be effective. Risks. So what are some of the risks of PrEP in terms of PrEP implementation? Well, there's been a couple reports out there, a couple concerns about risk compensation or behavioral disinhibition. So this is if people are on PrEP, are they going to all of a sudden be having more sexual partners? Are they going to double the number of sexual partners and overcome that protective effect of PrEP? Are they going to forego condoms altogether? Perhaps they weren't using condoms all the time before, but now are they going to use condoms never? And will that overcome the efficacy seen with PrEP? Finally, there's a number of different clinical side effects or worries that we're concerned about PrEP. One is side effects. This medication is very safe overall. I'm going to show you a couple things on the next slide. But there are side effects, especially a lot of the candidates for PrEP are going to be otherwise normal, otherwise healthy adults, younger adults. And the concern about putting some of these people on PrEP long term is something that we shouldn't do lightly. Also in terms of drug resistance, Truvada, so the way that Truvada works is it is an HIV drug. It is one that we usually use in combination with at least one other HIV medication. And so it makes sense that if we treat people with tenofovir emtricitabine as well as another drug, that when we take it as PrEP, it's going to build up in your system, and it's essentially going to prevent HIV from taking hold if you're ever exposed. Given that the tenofovir and tricidamine is part of a 3-drug combination that we normally treat people with, there is some concern that you're partially treating people, and if someone were to get HIV while on this drug, that there would be some resistance. That has actually not been borne out in the studies. It turns out that tenofovir is a very hardy and very good drug, and resistance is actually rare. Resistance is rare to tenofovir in the clinical setting with people with HIV, and it's also been rare in people who developed HIV in these studies as well. Finally, we also worry about long-term safety. There's a number of different concerns there, and certainly there is also concern for women who may be pregnant taking PrEP. This is a list of the adverse events on the IPREC study. I show just to illustrate a couple points here. The biggest side effect and the thing that we counsel patients most about is renal dysfunction. So we measure renal dysfunction by creatinine level. And in people who are on tenofovir long-term, you can see some dysfunction of their kidneys. And this is pretty much the major point that I counsel people on before I put them on PrEP. I say the one major side effect of this drug is it can affect your kidneys. It usually doesn't do it in an acute manner. It usually does it over a period of months to years. And we monitor your kidney function over every 3 months, and we would stop the drug before we see a decline. But this is sort of the biggest side effect that we see. The other thing, when someone first starts on PrEP, people may have a little bit of nausea and GI upset. And again, this is something that goes away. We're not talking about dry heaves. We're not talking about vomiting. But you can see a little bit of, people usually describe it as a little discomfort in their stomach epigastric region. And that usually goes away after a week or 2. The last sort of long-term effect that is sometimes worried about is bone mineral density. This is something that if you do some detailed bone mineral studies that you can see over the long term. We're talking about years. Out of all the people in our clinic who take tenofovir, it's very, very rare, and I can't think of a person that's actually had a bone fracture due to being on tenofovir. That being said, certainly as people get older and have other risk factors for osteoporosis, osteopenia, that may become more of a concern. However, that is listed as one of the concerns long-term of people being on tenofovir and something to consider as well. Besides those side effects, the drug is also extremely safe. Certainly, as with any drug, people can have any side effect, but those are really the 3 main side effects or concerns that people have, safety issues in people taking this drug. In terms of risk compensation, I want to present data based on two of the major studies that have this. One is the IPREC study, one is the Partners PrEP. In both of these major studies, which followed thousands upon thousands of people, they did not see any elevated risk compensation when people were on PrEP. So they did not find that people were having more sexual partners, and they did not find that people were using less condoms. You can see here in the IPREC study, this is partners, and this is the amount of receptive intercourse, partners in the last 12 weeks. You can see that the number of partners actually decreased, both for people on PrEP as well as placebo. This is the number of people using condoms for receptive intercourse. You can see the number of condoms actually increased for people in this trial. Likewise, there was no change in the average number of unprotected sex per partners or in the number of total sex partners per person in the partner studies. And the reason for this is that, at least in these studies, is that people are undergoing intensive education and counseling when they are on these drugs, right? So they're coming in for study visits, sometimes every month, and they're getting HIV tested, they're getting educated, they're getting counseled. And so at least in these major studies, they have not seen any change in risk behavior. Now, that being said, we're currently doing a qualitative study at our institution before people get on PrEP, and there's been a number of qualitative studies reported in the literature of small numbers of people in the United States. And there are people that are saying, oh my God, this is great. I'm going to be able to get on PrEP. I'm going to not have to use condoms anymore. So there are a number of studies out there, at least qualitative-wise, that are suggesting that there may be some element of risk compensation, at least in some people. Finally, talking about the impact of, this is the ultimate goal, certainly, ultimate goal of decreasing HIV incidence and prevalence in communities by implementing PrEP. questions that we have to ask are what percentage of the population do we need to actually put on PrEP, specifically of the high-risk populations, and I'll show some data from Rhode Island in a second. And then that has to really be balanced by the cost effectiveness. And I know at least one member of your group, David Paltiel, has published and is a much more of an expert on this than I am. To say basically that the cost of Truvada, which is $1,200 a month, really has to be based and targeted to people with the highest risk in order for it to make a cost-effective intervention. So these are the current demonstration projects ongoing in the United States. There's been one that's actually been completed. This was a demonstration project in Miami, San Francisco, and DC, where they basically looked at rolling out PrEP in the setting of STD clinics. In fact, this was just published in PLOS 1 with the lead author Liu, L-I-U. And they presented this at the CROI this year. So basically what they found, and this was one of the settings that I'm talking about where they have a very finite period of prescribing PrEP. So the site in San Francisco, they looked at rolling out PrEP in the setting of their STD clinic, but they're not planning on continuing that program past the point of this demonstration project. And they're actually having trouble finding community and people, doctors in the community to provide PrEP. So it's been a big problem with at least some of these early demonstration projects is finding out how to continue PrEP once they've finished these demonstration projects. And I'm certainly not going to go over all these studies, but just to show you that this is sort of really the first wave of PrEP implementation in the United States. The longest study is probably the one at the bottom. It's the IPREX open label extension. These are people that participated in the IPREX trial, and they're following in an observational way in the next couple of years to see what happens once they know that they're getting study drug and it's no longer placebo blinded. So what are we doing in Rhode Island, the smallest state in the country? So we were awarded a 18-month grant through the Gilead we applied for basically implementation project. And this is basically the step after the demonstration project. This is really looking at PrEP in a more of a clinical setting and trying to integrate all the variables that I mentioned a minute ago into sort of a real-world clinical setting. The people that we're collaborating with, and this is actually a two-site project, so I'm PI in Providence, Rhode Island, at our STD clinic, as well as Jackson, Mississippi. Our collaborator down in Jackson, Mississippi is Leandro Mina, and I'm working with Amy Nunn up at Brown for our site. We're also collaborating with Ken Mayer, Fenway Community Health, who's providing some logistical support. And the goal was really to implement PrEP into our STD clinic and looking at processes and barriers with that. So when you think about where and how to implement PrEP in a setting, I'm really a firm believer that in order to reach some of these high-risk populations, an STD clinic is really one of the ideal places to target and to reach some of these people. So I want to just take a brief segue now and just talk about our STD clinic in Rhode Island. So we used to have a public STD clinic that was funded by the Department of Health. That clinic was closed in 2011 due to financial cuts in our state. At the same time, and I'm going to show you on the next slide, we were seeing a sharp increase in STDs in our state. So beginning in January 2012, basically a couple of us just decided to open an STD clinic. And when we first started, we were really looking at just testing for syphilis and HIV. And that was because the syphilis rates in our state had tripled over the last couple of years. So we started basically a walk-in clinic Friday afternoons. We really tried to decrease barriers to testing. And we were able to add on gonorrhea and chlamydia. And the key about this clinic is that our institution was able to support syphilis, gonorrhea, and chlamydia, and we also got support from the Department of Health. And this is what was going on in our state, and I know that this is going on, and I didn't have time to look up the Connecticut epi data, but I know that this is sort of is similar to many other places and states in the country. What we've basically seen is really sharp increases across all the other STDs in our state. In 2008, our syphilis number of primary infectious cases of syphilis were 25. The last couple of years, it's been approaching 70. Similarly, with chlamydia, we have almost 1,000 new cases over the last couple of years, and gonorrhea has almost doubled. So our STDs in our state were certainly increasing. We had no basically public STD testing. If you wanted to get an STD test, you basically had to go to an urgent care center or a walk-in center. So this was an initiative that out of our institution that we started in order to address the increasing STDs. You also see on the right-hand side in red that this is a lot of times in the clinical setting, if someone presents with HIV, they also have another STD. This is the increased fold risk if you have one of these STDs of increasing your HIV transmission rate. HIV in Rhode Island, again, we're a small state. We have about 4,000 people estimated to have HIV. Our rates have really been stagnant over the last 10, 11 years. They have come down slightly. You can see from a peak of about 150, 170 down to about 70 or 80 the last couple of years. But overall, they've been pretty stagnant. The majority of these cases are in men who have sex with men. We've had a number of initiatives that have dramatically increased HIV due to injection drug use. You can see here, the second line down, injection drug use have gone to essentially, we've had 1 or 2 cases now a year. We have an excellent clean needle free exchange program in our state that was spearheaded by people like Jody Rich, Tim Flanagan, Kurt Beckwith, and essentially really dramatically cut down on HIV transmission due to injection drug use. Really one of the success stories in our state. However, at the current time, we're really seeing HIV, as many other places around the United States, due to gay, bisexual, and other men who have sex with men, has really dramatically increased over the last few years. You can see for 2012, it's about 50%. But the other thing I wanted to draw your attention to is that very last line, no risk reported. We do think that the majority, if not most of those people, acquired HIV through same-sex, men who have sex with men. So we do think that overall, based on the surveillance data, the numbers do show that the rates of MSM are significantly increased and probably much higher than they actually are due to not being able to capture some of the risk behaviors. The goals at our clinic were really to be it's based at our outpatient academic hospital clinic, but the goal is really to be more of a community clinic, to being friendly, culturally competent. We're really trying to be non-judgmental, respectful, etc., and normalize sexuality. We really encourage people to ask questions that they couldn't otherwise ask certainly anyone else, including primary care doctors. We do have a lot of people that come in who don't feel comfortable discussing sexual topics with their primary care doctors for a number of reasons. It was also actually a big point in the beginning, too, to make everything free. Certainly cost is a huge barrier. The cost of these tests is actually probably much more than you may think it would be. So let me ask a question to the audience. If you were going to get a chlamydia test, how much does a chlamydia test cost, a single chlamydia test? Any ideas? It's $100. So if you get a single chlamydia test, it's actually $99. So if you're getting a single chlamydia test at our institution, it's $99. If you're getting a single gonorrhea test, it's $99. HIV test is about $50. Syphilis test is about $99. So it's essentially close to $400. And some of the guidelines also suggest oral pharyngeal testing as well as rectal testing. So you're adding another $200 for throat for gonorrhea, chlamydia, $200 for rectal testing. So these costs balloon quite rapidly. And some of the guidelines also suggest screening for people, high-risk individuals, every 3 to 6 months. So you're talking over the course of a year, many thousands of dollars, which if you're uninsured certainly, or underinsured and have a high deductible, a lot of these are significant barriers to STD testing. We've gone from testing about 10 or 11 per week. We're currently averaging about 40 to 50 per week. These are our numbers as of 3 weeks ago. You can see we're still on an exponential increase. Part of this is due to advertising efforts, and otherwise, we do expect these to plateau out, hopefully in the near future. In terms of the people that we're actually testing at our clinic, we actually started initially as a men's clinic, focusing on MSM. Over 30% of our population is currently MSM. And 75% overall are men. Our age demographics, we do have a number, certainly when we try to reach out to these people, we do have a number of different racial and ethnic populations, and we are penetrating the younger age groups where STDs like gonorrhea and chlamydia are most prevalent. This is just some behavioral data from our clinic. It is a super high-risk population. Sex partners in the past year, 4.3. 30% have used drugs or alcohol during sex, 30% have reported anonymous sex, and these are just what people are reporting. They may be actually on the low side. 30% have a prior STD. Only 4% are injection drug users, and this goes to sort of the population that we're reaching out to. And then 9% have been incarcerated, 5% forced to have sex, 2% exchange sex for money. Before we implemented PrEP, we did ask people, had they ever heard of PrEP or have they ever heard of post-exposure? And this is sort of what we got back. And this is consistent with other places across the United States as well. It turns out about a fifth to a quarter of people across the United States have heard about PrEP or PEP. And again, these are the people, at least in our STD clinic, that could benefit most and the ones we're trying to target. So there is a huge education gap between the population that we want to target as well as the ones and people who actually have heard of it. Our rate of positivity for STDs in our clinic tends to be quite high. Over 10% of anyone walking through the door has an STD. Overall, our HIV prevalence is 1.4%. You can see that our numbers here reflect the overall trends in the country in terms of chlamydia being the most common, gonorrhea and syphilis being a little bit less common. Among our MSM population, we are finding a 4% seropositivity of HIV and 11 to 12% of syphilis, so super high. Part of this is because we are pretty closely involved and linked to the Department of Health contact tracing program, so they do refer partners to us, specifically for syphilis. We also started an initiative the last couple of years for post-exposure prophylaxis. We're running a post-exposure prophylaxis program now at our clinic. People can walk in during normal business hours and get post-exposure. People can also call in pretty much any time, our doctor on call, to get the first prescription, giving the timeline. Just to give a brief intro to post-exposure, I'm guessing most people have heard of it, but for people that have a sexual exposure, they can start Truvada and another medication within 72 hours. And it's been shown in the early studies, which dated into the 1990s, that if you take AZT at least, within 72 hours of being exposed to HIV, you can reduce your risk of HIV by about 80%. We do think that's much higher. We're using much more potent medications now, and we're not using just one medication, which some of those earlier studies did just with AZT. So post-exposure, I think, is a very viable alternative to HIV prevention, and I wasn't going to say any more of it on today. In terms of PrEP implementation, what are we actually doing at our STD clinic? So everyone, when they first come into our clinic, is screened for risk behaviors. And this is for the purpose of statewide surveillance reporting, as well as to offer education and counseling to individuals. So everyone, when they first come in, are asked to fill out a one-page sheet about some different risk behaviors. We then perform a rapid test, as well as tests for other STDs. Syphilis is a blood draw. Gonorrhea and chlamydia are urine tests. And during the time they're waiting for the rapid test, we do perform education and counseling, as well as discuss PrEP with the client. We have a one-page sheet that we go over that is meant to be more visual, just to discuss what PrEP is. And our strategy at our clinic has been to really discuss PrEP with all MSM. So we're sort of targeting the MSM in Rhode Island, and the reason is twofold. One is that the majority of people in our state, by far, are MSM. And the second is that we want to really disseminate information. So we have a number of MSM. So when we talk about MSM, it's certainly a diverse population. We have people that come to our clinic who are monogamous, have been with the same partner for years, and just for the routine, are coming in for the routine tests. And we also have people that are reporting 100 partners, at least sexually diverse population. Our thoughts were, in initiating this program, were that we really wanted to talk with everyone about PrEP, just to advertise, get the word out, and increase awareness in the community. If someone is interested about PrEP, we do schedule a follow-up appointment with myself or another doctor to prescribe PrEP. If someone has barriers like different cost issues, we have someone to call them trying to work through some of the different insurance issues. And that's been one of the barriers as well, is getting people insurance. So the financial barriers, though, haven't been paying for the medication. Again, I mentioned the medication was $1,200 a month. That can be covered, that's covered by most insurance plans. It's covered by all insurance plans if you have them. If you don't have insurance, there's actually a program through the drug company where you can get free medication indefinitely for PrEP. So getting the medication actually has not been a problem. The problem has been actually paying for all the labs, paying for the doctor visits, and paying for everything else that isn't covered traditionally with the medication. That's really been the challenge in terms of the financial barriers. The things that we're looking at in our implementation project are the things mentioned previously. One of the biggest ones that hasn't been looked at much in the demonstration project is the financial barriers, and that's something that we're also focusing on, cataloging really in detail why or why not someone can afford it, what type of insurance plan they're using. We are also specimen banking, so with every blood draw, when someone comes into the clinic, we are saving blood for use later. Part of that's going to be to check for drug levels if someone ever converts, as well as to look at resistance testing if someone ever seroconverts. I want to just show some very preliminary data. It seems like everything in the HIV world now is now a cascade, so I figured we will make a cascade out of this. What we basically want to show is the penetration of PrEP into our STD population. So if you start at the top, this is for the month period from November through February, we had 502 people testing for HIV STDs. Out of those, 32% were MSN. I mentioned again that MSM are the people that we're educating PrEP to about PrEP. Of those, we were able to educate 62%. So this is in the setting of a busy STD clinic. There are some people that walk out. There's some people that just aren't interested, don't want to be talked to. We were able to have counseling sessions specifically about PrEP. These counseling sessions are probably about 5 minutes to about 62% of the MSM. Of those, 50% were interested in PrEP. 10% actually had appointments scheduled for PrEP, and 5 people actually ended up on PrEP. At each point, there's a number of reasons why people were or were not interested, or other barriers associated with PrEP, and those are what we're focusing on addressing and cataloging in terms of our implementation project. These are the people that were referred through our STD clinic. There's also been a number of different people who have come in from other sources who are in our PrEP program. We have 5 people through the STD clinic. We have an additional 15 that we put on PrEP from referral sources, primary care doctors, et cetera, et cetera. So to date, we have about 20-ish, maybe a couple more, and we're putting on about 2 or 3 people on every week. We have patients scheduled. So future directions to finish up here. We are going to launch a statewide campaign to promote HIV and STD testing. The title of it is going to be Do It Right. You can see the RI stands for Rhode Island. It's highlighted. That was my idea. And you can see it's meant to sort of present in a visually appealing way as well as simple way. We're not trying to reinvent the wheel here, but we want to give people sort of different ways to protect themselves, including PrEP. And again, as mentioned before, I do firmly believe that PrEP is one of the tools that we use, and certain people can benefit, but should not really be the main strategy or the main push in terms of HIV and prevention. In fact, the main strategy should be get tested routinely. Obviously, people, once you know you're HIV infected, we can get you into care on medications, et cetera, et cetera. So the cornerstone of HIV prevention is really just encouraging routine testing. However, again, for some people, PrEP, as well as PEP and NICS and other interventions can be beneficial. Also, we're certainly looking for other clinical partners. This is part of my point of me being here today, is that we are looking to expand PrEP, and it would really be nice to get a network of HIV prevention clinics, which include PrEP, in southern New England. So certainly, if anyone's interested about the clinical or other aspects of PrEP programs, please feel free to talk to me or Elaine. And that is all. Thank you very much. I'm going to end there.